Association's Parent, Family, and Friends webinar series. Today we will be presenting Neurobiology and Disordered Eating, How Our Brains Guide Our Forks. My name is Ellen Domingos. I'm the Community Outreach Specialist here at NEDA, and I have our two wonderful presenters with us today. I'd like to take a moment to briefly introduce them. Our first is Dr. Scott E. Moseman. He has worked with the Laureate Eating Disorders program since completing his child psychiatry training in 2004, and he currently serves as medical director of the program. He is a board-certified child and adolescent psychiatrist who received fellowship training at Western Psychiatric Institute and Clinic in Pittsburgh, Pennsylvania, where he served as chief fellow. Dr. Moseman received his medical training from Texas A&M Health Science Center and completed his adult psychiatric training at the University of Arizona. He has spoken throughout the country on topics related to child psychiatry, and he has specific interests in eating, mood, and anxiety disorders. Currently, Dr. Moseman is collaborating with Cal Simmons, PhD, at the Laureate Institute for Brain Research to study neural circuits associated with eating disorders. Dr. Moseman is a strong advocate for families of eating disordered patients and serves on the board of the Oklahoma Eating Disorders Association. Hello, Dr. Moseman. Thank you so much for being here with us today.
Great. Thank you for having me.
Okay, and next we have Leah Graves, and she is the Manager of Nutrition Therapy for Laureate Eating Disorders Program in Tulsa, Oklahoma. Ms. Graves received her Bachelor of Science in Clinical Dietetics with highest distinction from the University of Oklahoma Health Sciences Center in 1985. She joined the Laureate Eating Disorders Program at its opening. A founding member of the Academy for Eating Disorders, Ms. Graves has served on the Academy's Executive Committee, Board of Directors, and has been honored as a Fellow in the Academy for Eating Disorders, in addition to serving on the 2013 National Eating Disorders Association Conference Committee. Currently, Ms. Graves is President of the Oklahoma Eating Disorders Association, serves on the Fellowship Selection Committee for the Academy for Eating Disorders, and is on the 2014 Conference Committee for the National Eating Disorders Association. Ms. Graves has been invited to present at the International Conference on Eating Disorders, Academy for Eating Disorders Annual Meeting, the National Eating Disorders Organization meeting, and the American Dietetic Association annual meeting, in addition to numerous regional and local conferences. Ms. Graves has also published several articles pertaining to nutrition and eating disorders. Hi, Leah. Thank you so much for being here with us today.
It's my pleasure.
Okay, so currently, everyone should be on the control panel slide. Now, we have everyone on mute right now to control background noise, but I do encourage you to participate by asking your questions. And you can ask your questions by clicking the hand icon to ask a question or a comment, or you can type in your questions or comments using the chat function. And I just want to let everyone know that we are recording today's webinar, and it will be archived and available to view again through our website at www.nationaleatingdisorders.org, and that will be under the Media Center tab on the webinars page. So right now I am going to give the presentation over to Dr. Moseman, and we'll start with the objective slide.
Great. Thank you so much. Thank you, everybody, for having both Leah and I here today. We are certainly well aware it's in the middle of Eating Disorder Awareness Week, and we are doing our celebrations here and hope that I know that we have sufferers and families and practitioners and everybody listening to our conference. So we're glad to have you here, and let's talk a little bit about the brain and talk a little bit about how it helps us treat people. So my objectives for today is I'm a big history fan, so I wanted to give you guys a bit of a history about, as a psychiatrist and you get diagnosis, if you've been diagnosed with an eating disorder, how does that happen? What is the history of how we diagnose those? And because that really does shape a lot, what diagnosis you get as far as what treatment you get, what research that you can use to do that treatment. So we'll be talking about that. I'm also going to talk about something called research domain criteria. This is something that is really set up, I think, as the future about how we're going to understand psychiatric illness. Psychiatry is one of the few specialties where, though we're dealing with biologic issues in brain and brain chemistry, that we don't get a lot of direct evidence from the brain about what's happening, and so I'm hoping that will change in the future. As we talk about specifically eating disorders, there's the idea of just how I understand the eating disorder on a daily basis, which is the idea of state and trait criteria, so that there is a state that you come into the illness with, or excuse me, there's a state that happens once you have the illness, and there's traits that that you have developed that puts you at risk for the illness to begin with. And then talk a little bit about neurobiology. I won't go into great depth. I do give longer presentations. If you're so obliged to see me someplace, I'd love to meet you. And I'm, of course, willing to answer questions when we're done. So let's get started. So the first slide is probably the worst slide in the history of slides. But the reason I put it up is that oftentimes when I'm asked to talk about neurobiology, there is this idea of how do I talk about a very complex thing. You're talking about millions of neurons and trillions of connections that make up how and what we are. And then even if I just stick to sort of that parts of the brain that deals with how we change food, you can see from this that there is external stimuli that are coming in. There's things like leptin and ghrelin and glucose, internal metabolism markers that make a difference. And then our brains have all these things that it's doing. Even exercise and stuff comes in. Even how our gut responds and how our brains, communicate with our guts communicate and our bodies communicate with our brains are extremely important. So know that this is really what this, and this is a simplified diagram of what's going on. We will not get this complex, but that every individual person, different ones of these boxes can make different impacts. And so we won't go into this much detail today, but this lets you see the system of how complex it is just to take in the right nutrients to get what we need, even if we don't have an eating disorder. So this actual whole thing is meant for somebody that does not experience eating disorder symptoms, and yet there is lots of regulation to make sure that we take in the right types of food, that we maintain our weight, and keep our energy levels up. So again, on the history thing, and I'll be a little bit brief, but you got to remember that until the 20th century, the diagnosing and treatment of any mental illness, the ideas of depression, anxiety, obsessive compulsive disorder, and of course eating disorders were really not seen as a separate specialty. There wasn't really separate psychiatrists that did that. So remember, before 1840, basically, you either were in a category of idiocy or insanity, in which you were kept in a place where your rights were taken away and you really didn't have much of an option, or if you struggled and had eating problems or depression or anxiety, you basically got along and did your best with minimal treatment or minimal interventions. The big change probably happened, especially after, World War II. Basically, the World Wars really allowed us to see that we sent our best and brightest off to war, and they came back having difficulties and having issues, and we realized about shell shock that became PTSD, and this idea that what was considered, neurotic or neurosis illnesses could really affect you and affect your standard of life. And, though it's not until the 50s or 60s that better biological interventions were about, we were starting to see that there are some treatments and that categorizing these illnesses can make it harder to distinguish them, research them, as well as treat them. So DSM-1 really came out. You can see as we get through the DSMs that they became more and more involved, longer and longer. And again, DSM stands for the Diagnostic and Statistical Manual. This is really the Bible that therapists and especially psychiatrists use to be able to diagnose illnesses, the different numbers. Obviously in eating disorders it has to do with anorexia nervosa, bulimia nervosa, binge eating disorder, and then now, what used to be eating disorder, not otherwise specified, but now feeding and eating disorder. So in DSM-1, again, most things are still, this is the heydays of psychiatry, which is, there's not much medications available, long-term therapy, and lots of things are determined reactions. And especially me being a child psychiatrist and eating disorder starting in children, basically an adjustment reaction was the only thing that you could even diagnose in a child this time. The idea that there is mental illness that starts in the teen years that affects you, that's due to your brain or due to genetics or anything happening, was really a foreign concept. DSM-2, we're getting to 1968. You can see there's more diagnosis. We're starting to sort of move away from psychodynamic thought, move away from the term reactions, that everything is sort of based and blamed on the family, though, as we all know, eating disorders became the last thing, probably not until the 90s, where blame of the family was really finally taken away from that illness. But it was still organized into basically you get strokes, you have problems with your brain that's considered quote-unquote organic, meaning something biological is happening, and other syndromes. At this time, remember, this is 1968. Homosexuality is still a psychiatric disorder at this time, and this is what every psychiatrist you go in could diagnose with. Autism at this point is not described. It's still described as schizophrenia, childhood type. And then the first eating disorder, which was just described as feeding disorder, came into play. And you're starting to see some ADHD, some sort of unsocialized, probably, conduct disorder stuff, group delinquent reaction, which, as far as I'm concerned, is all of adolescence. But these are all starting to considered as diagnosis, and this is, again, just kind of running up on 1970 now. We go to 1980, right? And so this is the first time, starting in the 80s, we're starting to realize that psychiatric illness happens in the brain, that we're starting to see that there is medication treatments that can be effective, that are changing brain chemistry. Research is starting to come up, so we start to have these ideas that there's a set of symptoms, and if these patients look similar, they have depression or they have obsessive compulsive disorder, then maybe certain treatments work on them, and we're starting to put them together. It's the first time that this becomes an international thing. So again, we're only talking about the last 34 years here, and that we even have diagnosis of anorexia, bulimia, that we're looking at other diagnosis, and we're starting to do serious research to figure out what's happening in the brain, what works, does what's happening in the brain relate to the symptoms that we see. And so this is a major change. Autism is introduced for kids, ADHD, ADD, and then again, finally, the eating disorders as we would describe them, or close to what we describe them now, are starting to be related. Again, still no binge eating or otherwise, but at least anorexia and bulimia. DSM-4 was what we were operating under until just this last year, right? So this is the first one which really is kind of partitioned out that you have to have impairment in your function. So it starts to be that important thing that I look at as a psychiatrist is that, when is it extreme dieting, when is somebody just having issues with food, and when does it clearly impact their relationships, spirituality, whatever else is important, their other priorities. Again, you're further splitting apart diagnoses. This starts the active 5-axis diagnosis, which we've now, again, done away with in DSM-5. And then again, anorexia nervosa, bulimia nervosa, eating disorder NOS is described at that time. So we move into DSM-5, and this was just released last year. And so the interesting thing in working as a psychiatrist is still all my billing and all the forms and everything, insurance, is all got to catch up and play catch up. So I find myself living in two worlds, DSM-4 with the way I'm billing, DSM-5 and the way I'm starting to look at things. Not major changes. Again, basically, when you make a diagnosis, if two psychiatrists make a diagnosis of anorexia nervosa or major depressive disorder, there's a good chance that if two different psychiatrists saw the same patient, that they would make the same diagnosis. How this reflects generally what's going on with their neurochemistry and how it works is sort of up to debate, right? So we know, let's take eating, for example. Even in depression, some people do not change their eating habits. Some people eat more. Some people eat less. There's probably different things happening. That first slide I showed you with everything going on, there's probably different things that are modulating their emotional brain and their part that's affected by depression and the part that regulates the way that they eat. And but yet it's really still the same diagnosis from patient to patient. They still both get major depressive disorder. So the nice thing about DSM-5 is that the changes is the anorexia nervosa lost the menstrual criteria. They lost the specific thing of having to be below 85% of ideal body weight. And they talked about significant changes and looking at developmental trajectories. And basically, I think, kind of bow towards looking at the individual patient. Both bulimic and binge eating disorder criteria went down to needing not as many times per week over a shorter period of time before you can make the diagnosis. And most importantly, binge eating disorder became its own diagnosis. Where that's most important, it's obviously not that binge eating disorder didn't exist before this time. It's just that when you define it as its own disorder, then also, people like the people I work with next door at the Brain Institute, then, NIMH and grants, and you can start to look at these people figuring out as a separate group and writing grants and writing research more to look at these patients now that there's a specific diagnosis, and we can start to have more information as far as better treating them once we kind of have a formal diagnosis. So you can see over time that we've generally created more and more diagnoses. Diagnoses are still generally built upon this idea that you have a collection of symptoms over time that affect function, and then based on those collections of symptoms, you make a diagnosis. So then, the question would be, so it's worked well, so what's the difference or what changed? So here is where it becomes important for me to try to define what's going to be different. And if you're a sufferer or you're a family member out there, then the importance becomes, this stuff sounds complicated. I'm glad that my brain is, it can be helpful to know that there's issues in my brain and I'm not just making bad choices or I'm not just a bad person, because that's very important. We know that Maudsley or family behavioral therapy uses the separation away. They use a lot of neurobiology to try to take blame away from both the individual and the family and really place it on the illness. But you would say, if you were just suffering from any other disorder, if you're studying from cancer or otherwise, then the importance is, well, what's really happening in my body, what researches are being done, what works better or what doesn't work. And the problem is with psychiatry is describing things as collections of symptoms. We've probably gone as far as we can in having to, you can just make that definition different, but you don't necessarily are looking at what's happening. The brain is really what runs our thoughts, what runs our emotions. And so I think the idea of research domain criteria is that we cannot change the way we diagnose things tomorrow. So the first way we need to change it is to change it by looking at research, right? So research domain criteria was put up by Tom Insel, who runs the National Institute of Mental Health, about 3 or 4 years ago. And the idea was basically that we start to better look at brain changes and how brain changes causes changes in behaviors, and that those brain changes can be treated directly, by therapy or by, medicines, that we're watching the brain changes as well as watching the symptom changes to know that a patient is better or feeling better. So research domain criteria really looks at mental illnesses as brain disorders with pathology affecting brain circuits. So then the question is, okay, great, how do I look at the brain, right? So people don't tend to frown upon having their skulls open and putting electrodes in the middle of their brain and other places. And so we've got to find ways to see how the brain's working while being minimally invasive, right? Because the brain's a pretty sensitive organ. So electrophysiology is one way. So this would be if you've ever been in and gotten a test like a sleep study, or you've been worried to have a family member that had seizures and they put the electrodes on, because the brain is an electrical organ, right? So for it to release chemicals and do stuff, the neurons sort of need electricity for that to work. And so the nice thing about EEG or electroencephalogram is that it can show in real time the electricity changes that happen. And that's really nice because the brain works very quickly and you want to see how it's working in real time. The disadvantage, again, is a lot of the interesting parts of the brain that regulate emotion, that regulate the way we eat and fullness and those kinds of things are found sort of in the recesses of the middle of the brain. And so it's hard to get electrodes up in there to see how the electricity is sort of changing in that parts of the brain. So that's not completely good for looking at those parts of the brain. The other is genetics, and we'll talk about genetics, so that, I want to be very clear that I do not think there'll ever be a single gene that will determine, if you have binge eating disorder, if you have, anorexia or bulimia. There might be genes that put you at higher risk or that make excessive exercise or eating maybe more of a risk, but this is probably several genetic conditions that sort of come together, and there's a perfect storm with the environment that creates it. But genetics are going to be important to let us know about how circuits work, maybe how certain chemicals in the brain are expressed too much or too little, or there's more than enough or not enough receptors in the brain. So that'll be an important part of looking at these circuits. The other is neuroimaging, and that's certainly something that I work with Dr. Simmons at. And there's sort of two types of neuroimaging. So there's positron emission tomography, which is PET. So the advantage of PET is it really is a good way at looking at the chemicals in the brain. So if you've ever heard of like dopamine, the feel-good chemical, or serotonin, which modulates in anxiety and worry and depression, or GABA, which is important for anxiety, norepinephrine. So these are all chemicals that operate in the brain, and PET basically sort of sticks a radionucleotide on so you can see how some of those chemicals work in the brain. So the disadvantage is it's nuclear and it's radiation, and you don't want to expose somebody to radiation too much, and that it takes probably, you have to be in the scanner and do something for, anywhere between 10 and 30 minutes, which again, not usually how the brain works. It takes a while to get there, but can be nice to see sort of the weather of how the different chemicals work in the brain. The next is what we do at the Brain Institute, which is fMRI. So if you've ever had MRI, that stands for magnetic resonance imaging. So a regular MRI really looks at how the molecules in our body respond when you put them under a strong magnet. And it really allows us to see different types of tissues and how that works. That's why when you look at an NFL player's knee, or you really want to know if there's something very small in your brain, MRI is a great technique to use for that because it sees tissues really well and in fine detail. A lot of studies we've done with people with eating disorders that show certain part of the brain gets bigger or smaller depending on whether you're nourished or this works, they use MRI for. Now the F, or the functional part, stands for in functional MRI, you actually are watching how the blood flow goes in the brain. And so we can infer that if a blood goes to a certain part of the brain and then it's deoxygenated, right, so that brain's using that oxygen for energy, that part of the brain is active. And so now we're talking about the bold window is anywhere from a few minutes to 7 to 10 minutes. So it's a smaller window, and we can kind of see different areas of the brain that are being active when they're doing tasks in the scanner. And so that's what we're doing here. And there's also these new methods where you look at proteins that aren't even in the brain or the cerebral spinal fluid, actually in your peripheral blood. And so there's a lot of proteins that are found in the brain, and it's sort of like a fingerprint. So you'll get this. There'll be 20 different proteins, and if they're in a certain structure, we know there is one test that can see that if you have a certain structure or a certain fingerprint of proteins, that probably means you might be at very high risk for getting schizophrenia. So it's a way to sort of look at the proteins our brain is spitting out in peripheral blood and looking again for fingerprints that might say, hey, some people with those fingerprints are more likely to have a certain illness. So you put all these together and you kind of develop a biosignature, which is sort of basically, it is the sense of, we all get history information, we get symptom information for patients, we're knowing what they're eating and what's going on. But biologically, right now, really the only information that we take in is what symptoms are coming out as a result of their brain being changed. And then we can also certainly look at, peripheral things in the blood. Is their eating disorder affecting their electrolytes or other kinds of things? From a genetic standpoint, I'm asking about family members. Do certain illnesses run in families? If they do run in families, has there been certain treatments that maybe family members have done well with? If Grandma June and Aunt Trudy and everybody had bad anxiety and they've all done great on Prozac, then if you're my patient and they're your relatives, then you might do better on that medicine as well. But right now, we're just not taking a lot of biological information. So this will not replace therapy. This will not replace adequate nutrition and nutritional therapy. This is really just augmenting, well, what else is happening in that brain, and how does that help us to understand that patient? And then how does it help us to individualize treatment for that patient? So if I can take, a quick genetic scan, see how somebody metabolizes meds, what their brain looks like. I can do a little bit maybe of a fMRI scan, which again is just magnets, no radiation, and then maybe do a protein analysis, and I say, oh, well, this is a patient based on their receptors and their genetics and stuff that, they might have a 70% chance of responding to like an SSRI like Prozac or Zoloft versus maybe only a lesser chance that they'd respond to a different type of medicine, or maybe this is somebody that has norepinephrine issues and maybe they need a Cymbalta or a dual-acting medicine, that we can start to maybe have some ideas rather than just choosing a medicine and then seeing if it works or not, to know kind of what brains will fit with what treatment. So, a good example would be sort of diabetes and syphilis in general medicine, right? So in diabetes, you have a problem with blood sugar, right? But there can be lots of different factors that lead to that change in blood sugar, and you don't want to treat all those the same way. So in depression, or certainly in anorexia or bulimia, there might be different systems that are off, and if you try to treat everybody the same way, that might not work. And any sufferer or anybody that does clinical treatment knows that not everybody looks exactly the same. There's probably different things going on. The opposite could be true too. So syphilis, or another good example would be like an autoimmune, like a lupus, where you maybe have just sort of one brain circuit that's off, but that one brain circuit, depending on the rest of the circuits, might come out with different symptoms in two different people, and yet you'd want to treat it the same way. That there might be one treatment that will treat somebody who ends up with this condition versus that condition, instead of just treating the end outcome, right? So if we're just treating people based on, well, they have depressive symptoms, they're having sleep and interest problems, they have an eating, they have anorexia and they're underweight and they have body image issues, they're binging and purging and have bulimia, we might be missing some of what's really causing those end symptoms, and two different patients with the same symptoms might need different treatment. Just like if you go in and you have, fever and nausea, and you could have 3 or 4 different illnesses. That's why doctors run tests, and if you don't have, a positive test for bacteria, maybe you don't need an antibiotic. If you do have a positive test, then what kind of bacteria do you have, and what is it sensitive to? What's going to work on that? I mean, that's the hope of where we'll go in being able to look at brains. So then what does this mean for eating disorders? And so what I want to go over is just the way on a daily basis that I look at this illness. And so this illness comes from the fact that if you look here, everybody walks in with a brain that has a certain amount of risk. And luckily for us, majority of people do not have a brain that's at risk for an eating disorder. There's too many protective factors that make us want to eat, make us want to keep our food down, make us want to regulate our body and do right, that most people, even if somebody's mean or they have a mean gymnastics coach or they go on a severe diet, that their bodies will respond and they'll end up staying out of the eating disorder. But if you have a brain with risk and then you run into some environmental problems, then you develop the illness. And I put here anorexia, bulimia. You could certainly put in other eating disorders or binge eating disorder here. And there's something about having these illnesses that I call sort of the quicksand that keeps you sort of stuck in this illness and makes it hard to get out of. And so we're going to talk about the traits, we're going to talk about environmental stuff, and then talk a little bit about the quicksand, the parts about being malnourished or the parts about being stuck in these illnesses that make it so difficult to treat. And this is the neurobiology of how I see, somebody who steps in my office on a daily basis. So the first question, so again, as we discussed earlier, we're defining them by collections of symptoms. These are mental illnesses, so they do sort of have this lack of perspective. Might have great perspective around things, not around their eating, but when it comes to food, exercise, proper weight, they lose that perspective. That's the mental illness part. And again, so there's these traits. There's your brain and how you're born and how you're raised. I'm not sure if anybody's out there as parents, but I have 3 kids, and they are extraordinarily different. And their traits probably put them at higher risk for certain things, if you're going to be more daring or introverted or extroverted. And so these traits are probably more hardwired and are probably less prone to being changed by environment or changed by medicine. The other thing that happens is that once you get sick, especially in eating disorders, again, these states, it's the quicksand, right? It's the binging and purging cycle for bulimia. It's the binge eating cycle for binge eating disorders. It's the cycle of being chronically malnourished in anorexia that sort of keeps you stuck. makes it hard to seek out care and makes things more difficult. So what does this mean for treatment? You have to fix the state first. Someone has to be properly nourished, right? If someone is binging and purging, they need sobriety from those symptoms. The brain needs proper energy, and it needs to be in a restful, capable state of working on then alternative coping mechanisms, right? So then you got to figure out, how did I get here? How did my anxiety drive me, or my depression drive me, or my environment drive me, and how do I make changes so that I can keep myself nourished, that I can keep myself sober from symptoms, and put my priorities in the direction that I want to get them into. So, though you sometimes think when you do sort of neurobiology and everybody's just a brain and nobody is the same, it actually is quite the opposite. The brain is this amazingly complex organ that makes us who we are. So actually, the more I look at more about neurobiology, the more it actually gets me to look at collections of symptoms, but it gets me to individualize the patient. What does their particular neurobiology look like, and how does that make a difference? Some people, let's say like Leah might talk about, are really capable of doing a lot of variety and differences, and you want to push them to eat everything they eat before they got sick, and they've been sick for a couple of years, and you want to get them back to intuitive eating and not being on a huge meal plan and not having to count everything and do stuff. And then there's going to be some patients whose brains just work where they'll need to be on a very specific meal plan. It'll maybe need to be simplified, and they maybe have to take almost their food like medicine just to keep their brain nourished enough where they can make other decisions. So again, very different, and certainly not a one-size-treats-all type of treatment. So let's look at anorexia for a minute. So, when you look at temperamental traits, and again, the way they do these studies is they take a look at people who develop the illness, they take a look at people who have never had the illness, and even the people that have had the illness, a lot of times these are people that are in recovery, that are not actively, participating in symptoms, and they say, well, what have you always been like? What were you like growing up? And a lot of these traits even persist after they get well, even though they're doing well. And they look at the symptoms that are different in those people that got anorexia as opposed to those that didn't. So, one of these symptoms is negative emotionality and low self-esteem. So this is a hard one for people. So the fancy word is these people are a little bit more pessimistic, and they really don't see themselves or how the world sees them in the same way that somebody with a better perspective would. And this is a hard one, especially living in the United States. I mean, we believe that if you just try hard enough and work hard enough, you should be proud and accomplish if you achieve things. But anybody who's worked with these patients, or especially if you're out there and you're a sufferer or a parent of a sufferer, you know that a lot of these young men and women are extraordinarily capable, extraordinarily intelligent. They're the girls that everybody wants to babysit their kids, and they're valedictorians of their high schools, and they're the head of their key club and everything, but they just don't see it that way, and they've never seen it that way, and this thing runs in families, and it's probably genetic as well, and so that low self-esteem can sort of run the eating disorder, and again, it's something that exists before they ever went on their first diet or ever had their first binge and purge. The other one, which certainly people know, is this idea of perfectionism. And this is the idea that even before their eating disorder, it was things had to be certainly exactly so. And that, and if it's not certainly exactly so and their picture doesn't fit, then they end up being anxious, right? So this anxiety, perfectionism, needing to be a certain way really kind of defines who they are. I would argue it defines how their stomach works when they grow up, and how having upset stomach and headaches. I've had more young women with anorexia who are 15 who come to my program sick, who have never been away from home for more than 3 days. I mean, this is, that they see the world in a certain way. It really needs to go a certain way. And when they get overwhelmed, they inhibition is what happens. They turn to step away. They want things to be simpler, not complex. They get very easily overwhelmed. Sometimes we call this like a turtle temperament, that they want things get overwhelming, they want to make things simpler, they want things predictable, and they want things just so, and it really upsets them when it doesn't work out exactly as they are. And then even if they do well, right, the problem is, because they will go down a little bit, they have lots of reward dependence, they want, and they're not very reactive to when they get reward. So what happens is they do accomplish things. People are proud of them, but they just don't see it. It doesn't feel genuine. It wasn't just quite right. You can see sort of this anorexic temperament that's always developed. It's great for going to med school or law school, right, being able to put things off and do things. And so a lot of these young women, again, these traits can be used to accomplish things in life and do stuff, but in the service of the eating disorder, it becomes overwhelming. Another thing is ultra-interoceptive awareness. It's a fancy word for they really don't feel their body and what's happening in their body, their heart rate, their stomach, their fullness, the way that people that do not have eating disorder experience it. And there's some thoughts that that interaction between the mind and the body really doesn't work right. And over time, food changes that, their experience with food changes that, and creates sort of this circuit of sort of their mind and body being at war with each other. That's actually one of the main things that we're looking at the Brain Institute, is this part of the brain called the insula, which really connects to the body and sort of is the brain's first feedback about the body. It sort of doesn't see things quite right, and then it sort of collaborates with all the other areas of the brain to sort of believe that your stomach and your energy needs and everything are not what you need, and can certainly develop into, you know, full-blown anorexic traits. They also have a lot of obsessive-compulsive personality traits. I'm a strong believer that anorexia strongly has a foothold in anxiety and OCD. You know, rates of OCD and anorexia are in the 30 to 40% range, probably 8 to 10 times greater than they are in the general population. So again, some people would say if you take away fear of germs and hand washing and you put in fear of calories and fear of becoming overweight and not eating, that you might have sort of OCD-type circuitry, which I think can definitely be present in some patients. Again, inhibition, harm avoidance, this whole sort of life gets overwhelming, they take a step back, and then they're not rewarded by the great things that they're able to do in life.
And Dr. Moseman,
you take bulimia, they do these same studies.
Dr. Moseman, if I can interrupt for just a moment, we did have a question come in about anxiety and anorexia.
Yeah, go for it.
Where they've heard that there's a link between the two, where self-starvation actually calms the anxiety. And they wanted to know if you could discuss a little bit more how this is related specifically to the neurobiology.
Absolutely. And so what I'm going to do is I have a slide, trying to think of where it is, about 3 or 4 for now, that's going to talk about that state-dependent thing. So again, when they starve themselves, what changes? And I'm going to specifically talk about how it helps and quells their anxiety. So we'll definitely talk about that. That's a good question.
Great. Thank you.
Okay. So as we move on to the bulimia, the interesting thing is we know from genetics that there is sort of a lot of cross genetics between bulimia and anorexia. Again, there's probably some circuits that are in common. Some people during their lifetime will meet criteria for both illnesses at some point. So, you know, but if you think broadly, and again, on the anorexic being sort of more timid, more on one side, the bulimic being maybe a little more extroverted on the other side, you still see this negative emotionality and low self-esteem, which is important. These girls sometimes are very social and capable and still are very, you know, you wouldn't see them as somebody that should not think well of themselves, yet they don't. They're also anxious and fearful, and this can be a hard one because this ties together with this mood lability and impulsivity. They're often seen as more social, more capable, more out there. They enjoy, you know, to go to the party and to do things, and so you don't think of them because they're out there possibly being impulsive around drugs and alcohol. They're possibly being impulsive with other things as, well, anxious and fearful looks to me that hides under a shell. Well, what happens, and the way I sort of view this, is bulimics are still anxious and fearful. It's a little bit different change in that when they get anxious and fearful, and I'll anthropomorphize this a little bit, they really say, I feel bad, and so how do I feel better right away? So a lot of their behaviors, whether it is binging or binging combined with purging, is really an effort to release or relieve anxiety or other symptoms for them, like I need to feel better right now. Unfortunately, oftentimes these behaviors lead them sort of deeper into the drift, right? And then instead of sort of backing up and making things simpler, sometimes they accelerate their behaviors and can get it more and more and more, where sometimes they're binging and purging multiple times a day. They're not getting as much reward from that circuit, and they're, you know, and again, they're still trying to address the same thing, which is, I don't feel well. They just choose something that sort of makes their brain feel better right away. You know, restriction takes a lot longer for the brain to sort of feel relief, where a lot of the bulimic is sort of more impulsive. It drives dopamine, the feel-good chemical, and it makes them feel better. Also proves why in this temperament that bulimics can be at higher rate for drug and alcohol use, sexual addiction, any of the type of impulsive behaviors that make you sort of feel good in the moment, but maybe make things a little harder for you along the way. The other thing is this idea of mood lability and affect dysregulation, right? I see more bulimics come into the hospital and others given a diagnosis of bipolar disorder, right? So just having mood lability, your affect being dysregulated, especially if there's been some trauma or something, does not necessarily mean you have bipolar illness, right? And bipolar medications are very serious, so you really want to make a good, accurate diagnosis on what is just my world's spinning and things are chaotic and I'm binging and purging and life is sort of spiraling versus do I have true manias where I stay up for 3 days and I don't sleep and I have hypersexuality and grandiose thoughts, because the treatment and medications are very different. A lot of the medications for bipolar disorder can have serious side effects, and so you want to make a good diagnosis. And knowing that their temperament's like that, I see a lot of misdiagnosis in bulimia that happens. I'll be a little more brief on genetics. Again, I said earlier there's no one gene, and so it's probably a combination of genes that puts people at risk. So, but there is, when you look at people, when you look at twins, monozygotic twins that have the exact same DNA, the way to know if somebody is, if an illness is completely due to genetics is that 100% of the time if one twin gets it, the other one will. Huntington's disease is a great example of that. It's on chromosome 4. If you get it, anybody that watches House knows that the girl knew she had it. This is actually some of the worry about getting complete DNA studies on babies. You find out that they have this illness, how does it change out who they are, how they live, or how things go. But when you do these studies when somebody has the exact same DNA, between 50 and 80% of the time, if one develops symptoms, others will as well, that there's some variation of the illness. So there definitely is a genetic component. It is similar to schizophrenia and bipolar disorder, so it's not necessarily any more or less heritable than those illnesses which we know occur in the brain. They're cross-transmitted in families, so if you have a family member that has anorexia, you're at increased risk for both illnesses, again, showing some circuitry is probably shared. Similar to OCD, that even if you don't have the full illness, family members still might have some eating issues or exercise issues or body image concerns. And then again, we're not going to find anything that's going to entirely describe the illness, so then we look at those little individual circuits, right? So we're looking at, well, does this affect self-esteem, or does this affect serotonin and how somebody responds to exercise or anxiety, egosyntonic vomiting or binging? Is there a reason why some people will get that positive reward or not? So these are probably the smaller areas of where genetics will probably go. So this would be an example. This is done in science, and it's a great example of, like, they were looking at a specific serotonin transporter, and if you had the long one, it was sort of safe for you. The short one was sort of at risk. So here's that long one. Here's the short one. And the probability of depression lifetime is about 9 or 10%. But then as you had stressful life events, a divorce, death of a loved one, something else happening, loss of a job or something, that your brain's ability to put up with that stressor was protected, so you only went up to 15% if you had a long version, but if you had the short version, your chance of depression went up to 40. So this might be exposure to energy deficiency, excessive dieting or excessive exercise, that maybe over time there are certain factors that are protectors that keep people from getting eating disorders and certain circuits that maybe put you at higher risk. And I think this is sort of where these genetics are going to push, how many people try vomiting and how many people have maybe an egosyntonic gene or not. So those things I think will be where we'll be heading. So then if you have a brain, then the question is, what do you go through that can make it better or worse? Especially for females, and I know I don't ever want to leave out males with this. Unfortunately, again, for anybody who knows or does research, we need more research with males with eating disorders. Luckily, it's becoming more commonly treated. We have more subjects. In females, obviously, estrogen change is a big deal. There's a reason why as a child psychiatrist, most of my practice below the age of 12 is males, most of my practice above the age of 12 is females, and that's not just eating disorders, that's everything. And some of that reason is that estrogen changes Serotonin, which is, again, is that sort of anxiety and modulation hormone. There's cortisol, which is the stress hormone. And then there's these two circuits. So frontal circuits are the area that allows us to make decisions. Limbic circuits are the areas that control emotion. So these change a lot, and it's basically they're changing so that people can they're coming to reproductive age. They're able to be good mothers who are caring and do stuff. And I always consider it's like a volume switch. Like you turn the volume sort of on compassion and empathy up too much, maybe it sort of turns into anxiety and being too overwhelmed. Too low, it seems disconcerting or distant. So that changes with estrogen changes. And again, that's one of those hormones that creates a cascade of other changes that affect the brain, that affect the body. Complexity, body weight changes, other mental illnesses coming on board. Puberty is just this sort of, especially for women, for men as well. I actually consider it to be a little more of a risk for women. Kelly Klump and some of her group are doing really great studies that looks at, well, how are different parts of or different circuits in the brain affected by estrogen changes? How might that lead you to possibly have a greater or lesser chance of getting an eating disorder? Then there's the idea too that just psychologically, as you're going through your teens, sexual abuse, when they've done studies to show that even not perpetrator otherwise, but things that end up being inappropriate sexual touching that can affect people, other types of trauma, domestic abuse, etc., an increased propensity in our society for it to happen, and then how does the brain that's sort of still ripe and trying to figure itself deal with that? And then just our culture. So we sexualize women way too early. We put kids under way too much pressure way too early. We live in a fat-phobic culture that believes that thinness is the ideal of success, that being normal weight, being slightly overweight is the idea of being, slovenly or not capable, when that's just, it's not designed to what's true. There's plenty of people who are thin who don't do things and who are not particularly watching their diet just because of their metabolism or how they're made, and there's people that are overweight who are very healthy and capable and taking care of themselves. So, but again, when you're in this culture, you're worried about your weight, you already don't see it how it is, that's a huge stress, which I think puts more pressure on brains and makes more illness potentially come out. Luckily, most brains aren't meant to get illness, but that pressure certainly doesn't help. And so then there's the idea I know that people were talking to, and I want to try to get this done by the time that we hit the 12 o'clock hour, that then once you get into the illness, then you get into states that make it harder to stop, right? So once, the great study that was done, the Minnesota starvation experiment, probably could never do it nowadays, but they took male conscientious objectors, and they just saw what happened to them when they didn't eat. And they got depressed. They worried about their stomach and headache. They were preoccupied with food. They were isolated. They were socially withdrawn. And these are all kinds of things that if you're an anorexic and you're being malnourished are not great ways to seek out and get help. On top of that, someone mentioned the simplicity factor, right? So all those hormones that might have been making your brain a little bit, not work quite right, or turned up the volume a little bit for the anxiety or depression and stuff, those go back down, right? And so your brain feels a little number, maybe feels a little bit better. Serotonin, so we know from Walt K's study that the limbic, the emotional system of the brain has some excess of serotonin. You need serotonin from your diet. That decreases. So the way I like to look at it is that, families will say, well, I lose my daughter. She loses her sense of humor. She loses, all this brain chemistry is sort of like tunneling down into sort of a dark, very simple place. The patient will say, well, my brain was crazy. I was overwhelmed. And when I stopped eating, it made things simpler. It made my brain, made my brain have less anxiety. It made estrogen affect my brain less. And all these things probably do make them feel better. I never can emphasize this enough. These patients do these behaviors because it makes them better. The problem is, over time, there's stuff like corticotropin-releasing hormone, which causes dysphoria. There's decreased beta endorphin. All of these make them feel worse in the long run, more activity, decreased feeding or desire to eat. And so you can continue to see how this gets in a cycle. And I have this slide where basically you diet, decrease serotonin, estrogen, you maybe feel a little bit better. And you can change estrogen levels even before your weight changes just by your choice of foods. Then you start to feel worse, right? Corticotropin releasing hormone, decreased beta endorphin, you start to feel worse. Well, I felt better when I dieted the first time. Maybe I just need to diet some more, or I need to lose some more weight and I'll get some more relief. And if we do, as professionals, what we're supposed to do, we make people feel bad. And that's what makes my job hard. Anytime you're a physician and you give people a treatment that makes them feel worse, the chances of them following through are down. Never mind the fact that they distort the way they see their body, that they can't see things otherwise. And this is what makes treatment so difficult, is that it does make them feel better, and treatment in the initial stages makes them feel worse. Anybody out there in recovery can certainly know in the long term everything is certainly usually almost always much better, maybe still some anxiety or stuff, but in that short term it feels worse, and that makes treatment very hard, and the brain is really responding to that. From bulimia, again, you get this disconnect between body images and urges, right? So a lot of times they're binging and purging. I'll put, though we don't have the research, I'll put binge eating disorder in this mechanism too, right? You know, a lot of times there is dieting, there is a decrease of energy intake to try to affect your body and do stuff, but the brain's trying to fight back. It really needs to take in energy. It realizes it's not enough, especially when exposed to simple carbs, which provide instant energy. You know, you take it in and you feel better. There probably is some model that's the same as other excessive behaviors where there's, again, more of a reward from the binge. There's this dopamine release, a feel-good release in the moment, though you certainly feel worse over the long term, that makes you feel better and that makes things go better. I would also argue that most people in bulimia that purge, or any of the undoing behaviors, again, it doesn't have to be purging, that there is some relief from that. So they're really seeking out trying to feel better. It just doesn't make the baseline situation work. And you can see it creates a spiral of making things worse and worse. Well, I need to do more of it to feel the same. So there is that sort of addictive quality that works the same way with sexual addiction, drug abuse, alcoholism, gambling. I don't want to put that exactly the same mode, but basically they're trying to feel better. That dopamine system gets going. And so, again, the goal, again, is about sobriety, getting the brain out of that sort of intermittent excessive dopamine exposure. So, again, you get in a brain that has risk or doesn't have risk. It walks into an environment, puberty, pressure, too much school, too many things to do that create stress. Maybe it creates anxiety or something else. It creates depression or other illnesses which kind of press on it and create, you know, the idea that by eating or binging and doing some sort of undoing becomes the solution. And then the problem is if those behaviors create their own sort of quicksand that makes it very difficult to get out of. It makes it, you know, so that you really have to get them sober, eating, correct energy, correct nutrition before their brain, which still has some difficulties, can simplify the environment, before it can make really good use out of therapy and think of other ways to sort of think around the brain and these parts of the brain. Now, I'm not going to go into detail on this. This is a Nature review by Walt K. But you can see these certain parts of the brain that are, you know, this is the part of the brain that's available and it coming in. We can see the part of the brain that's involved in PTSD and emotion is involved. That all these different brain areas are involved. Now, this area of the brain, this is the area of the brain where therapy can really get into. And so this is an area of the brain that's a higher cortical area, and that this is an area of the brain where if therapy can work, it can sort of like numb down these areas, right? You can numb down these areas by not eating, but you can also change your brain chemistry, whether it's through meds. Now, there aren't any specific meds that make the thoughts of, you know, body image distortion and stuff go away. However, if you have a medicine that helps with anxiety, that helps with your depression, so it puts less pressure on the system, you do some therapy to be able to realize that, oh, I have distortion, I need to eat because I only, you know, when I have energy, I'm able to do stuff. And all those things can sort of quiet the system down, which gets revved up, the emotional system, which really gets revved up and overwhelmed. And so that's the sort of goal from treatment. And I think the better that we understand how these systems work and interact, there's even been a recent study done that shows that they put people in a scanner, and when there was a change in a certain area of the brain, I won't go into detail, that if there was a big change in that area of the brain, that those people did better and responded to medications better. and maybe if there was a smaller change in that area of the brain, those people responded to therapy better. So there are already some ways in which, I would still say both therapy and meds are always the best choice, but just showing maybe if someone's not responding to therapy that you can put your foot down on the medications, or if somebody really just wants to do medication, doesn't like therapy, you can say, well, your brain really needs to change and do the therapy thing. So this is still years away, but I think we're getting to the point where knowing about this as a doctor, me knowing what I'm changing, can really hopefully have us have some really breakthroughs in how we treat this illness and how we do things.
And Dr. Moseman, we had a question come in about pertaining to amygdala. The question is, what is the role of the amygdala during starvation, and how do quote-unquote fired up amygdalas and high cortisol levels impact cognitive functioning and the recovery process? And they also wanted to know what the impact of not eating adequate fats and calories is on the myelinization process of neurons, especially in adolescents, young adults, and how this may impact learning, decision-making, cognitive processing, and brain development. If you could talk a little bit about that.
Well, it's obviously a question from somebody who knows exactly what they're talking about, and I'll leave some of the myelination stuff up to Leah. The amygdala, for all kinds of reasons, the amygdala is sort of the alert area of our brain, and so it's certainly something, cortisol levels is sort of stress hormones in the brain, because I want to make sure that I answer the question where lay people can sort of understand what's going on as well. So whenever these areas, the amygdala is considered, my lack of scientific term is it's the holy crap area of the brain, right? It's the area of the brain that lights up if you're feeling good. It's the area of the brain that lights up, when something's bad or doesn't feel good. Certainly when people have had trauma, this area of the brain gets lit up too much, and cortisol levels or stress hormone levels can affect that. And certainly I think whenever your brain is sort of driven by this, these types of, being activated, being fearful, so I think people think of amygdala as a fearful response or a fear response that happens right away, then, absolutely it affects their ability to make decisions. It really sort of crowds the weather of the rest of the brain. And cognitively, there's lots that happen, obviously, when your brain's better nourished, myelination, how the brain works together, that is extremely important. Everybody that does therapy knows that somebody who's weight restored thinks better and on a different level. Now, the amygdala, how it affects cognition, I think it's that if you're in the midst of a crisis, everybody think about being in the midst of a crisis and how well you think and plan things out and cognitively do stuff. Well, that amygdala is firing is telling you sort of you're in crisis and you're in a bad place, and I think it makes it hard to plan and get things done and do what you need to do. Where if, again, the rest of your brain, especially those frontal parts of the brain that can quiet that down, once they're better nourished, once you're getting exposed to food and you're doing it more often, you do some exposure and response prevention, and you can quiet that amygdala down, whether it's therapy or meds or a combination of nutrition, then the rest of your brain can kind of deal with a less noisy environment and possibly be able to make better decisions and do things. And so, that's a question I could probably spend an hour answering, and I'm sure whoever asked it probably could spend an hour answering it as well. I think it's a great question. It's a question I think anybody in neurobiology is sort of trying to answer about, okay, so how does this not only affect where they're doing, but how does it affect cognition and their ability to respond to treatment? And that's a super important question that, I know that, people like, Walt Kay and Guido Frank and all those people doing great research out there are really trying to figure out, where the rubber meets the road. How does this make a difference for individual patients, how they're thinking, and how they respond to therapy? So that would be my quick answer. And it was still pretty long.
Thank you very much.
All right, well, I'm going to hand it over to Leah.
Thanks, Scott. All right, so now we're going to get to our plate. So what I'm going to try to do with the last portion of our time together today is talk about some of the things as a dietitian working with this population of individuals that I have to consider from Dr. Moseman's talk when trying to craft and assist people in developing recovery-oriented eating habits. And I'm going to break this down by diagnosis and do our best to try to conceptualize. There will be some repetition in it because I'm trying to drive home some points here to help people think of things more conceptually along those neurological lines and temperamental lines, because that really impacts how I believe we need to inform our care. So we're going to start with anorexia nervosa. Certainly it's been studied the most that I've been able to evaluate in this area. And what I really think about here is that these individuals have a decreased drive for food consumption, and now you are starting to understand neurologically why that might be. But they're having this in the presence of actually needing fuel and not meeting that need well. And so you've got this soup of neurological, biological mixed together, but these folks are desperately trying to simplify to calm down some of the things that are really chaotic for them. There's also some pretty decent evidence to suggest that their reward from eating is different than folks that do not have an eating disorder, so that some folks may have a little bit of a more difficult time from a palate perspective accepting things that you and I may feel like they should be engaged with. There is definitely difficulty in maintaining new eating habits. Janet Shevendock and our colleagues up at Columbia have done some great work in looking at, even though in structured treatment programs were able to affect change, that it's really hard for folks to hold on to that when they leave, and trying to understand what are strategies that we can use nutritionally to maybe help with that a bit. And we really, as a young field, do not have scientific guidance as to optimal feeding methods or dietary composition. So what I mean by that is we don't know how to mix protein, carbohydrate, fat, vitamins, and minerals optimally to try to re-nourish these individuals. There's very little been studied on it and no consensus or no guidance at this time. So what we have here are some really big challenges to the treatment providers and to the families and to the sufferers themselves. Often people have an elevated anxiety when presented with food. There are often behaviors that interfere with intake, like hiding food and food refusal, weight manipulation, excessive activity and purging. There are eating patterns that drive the state that Dr. Moseman discussed earlier for the anorexia nervosa sufferer, and they reinforce these eating challenges. It would be great if we could unreinforce them, that in fact their intuition is to avoid nutrient-dense foods, to avoid quality protein foods, often avoidance of fats, and a limited range of variety. I think of these folks as their plate is getting simple. They're trying to lessen that overwhelm and chaos by getting simple. And in fact, when we look at nutrition histories, when folks are presenting for treatment, that's in fact what they've done, is simplified very, very much to very often, in my case, when I ask about foods you're comfortable eating, less than 5. It's very, very, very simple. But at the same time, ironically and almost cruelly, we know these folks have robust energy needs, often requiring 2 to 3 times the amount of energy that a non-eating disorder sufferer may require. So you have someone who's overwhelmed by quantity, overwhelmed by density, overwhelmed by variety, and yet their needs are more than their peers. So it creates a very cruel treatment situation where what is needed and what is tolerated psychologically and sometimes physically are very, very different. These energy needs tend to increase over time, especially in our restricting population, and yet there also are consequences that from malnutrition to the GI tract, and as Dr. Moseman pointed out, thinking that in folks with eating disorders there may be a really tight zippering together of the gut-mind connection, so that it really makes it challenging for a sufferer to make the changes necessary to heal their body. We've discussed these eating patterns, but I always like to go over that. So we have an inadequate total energy consumption, an over-reliance on high-fiber, low-nutrient-dense foods, inadequate protein consumption, so we're not getting building blocks for neurochemicals, building blocks for maintaining body tissues. There's often an over-reliance on low-quality protein sources, so a lot of extreme vegetarianism, not balanced, but extreme. Inadequate total fat intake, so that gets into those fatty acids that were asked about earlier, and avoidance of foods that provide these essential fatty acids that we know are necessary in the maintenance of myelin or development of it in our younger population. And there's also poor diversity in food selection, and a lot of parents will ask me, well, that doesn't really matter to me. And in some cases, we have to work with where a person is, but what we also know is that's incredibly protective to human beings. It ensures nutrient intake. So we want to get folks to the best diversity in their selections they can be, because it's protective for them in the long haul. So when I'm doing meal planning with someone with anorexia nervosa, I look at certain things. These are the considerations that I'm working with. I have to realize that energy needs are high, and that use of nutrient-dense foods is going to, with a smaller volume, get the job done better. And as Shevandock and colleagues have demonstrated, the folks that tolerate that tend to do better and not come back to hospital. I'm working with a population that may have a lot of rigidity about their thought processes, that has an anxious temperament that doesn't like change very well, and may have alterations in their reward associated with eating palatable foods, which tend to be those more nutrient-dense things. So those things all have to be considered when making that plan. So this is my strategy that I'm working from, is that I have to recognize these challenges and focus on an initial eating plan that provides adequate energy, high-quality protein, and essential fatty acids. And then I have to be upfront and honest with this individual in acknowledging that there may not be much reward for eating, and being truthful about what needs are, and understanding that those aren't things we get to choose. These are the cards that we've been dealt. So how together are we going to creatively meet those needs in a way that that person can tolerate it? To consider eating as a means to obtain essential nutrients for brain and body first, and not maybe focus on pleasure quite so much early in the game, because it's just too overwhelming and may not even be very valid for that individual. To consider weight as a vital sign, and it's integrated with other medical parameters, not as an independent indicator of well-being, so that we're monitoring and we're encouraging weight restoration in the individual that needs that, but not making that the only thing and eliciting more and more and more terror. We want to address that energy dilemma with the sufferer directly, that, oh, we have a challenge here. How can we meet this challenge together? And with the highly rigid folks that are suffering with the brain that really, really can't flex much and really is so overwhelmed, I structure it up quite a lot, using highly structured meals initially that address variety. I may even go with a 3-day rotation of exactly what we're going to do so that there's some variety. I chose 3 days because it's an odd number and it doesn't have the symmetry, so it challenges some of that rigidity, but at the same time is kind, and then gradually increasing that. And I insist all macronutrients, all protein, carbohydrate, and fat must be represented in the meal plan. Nutrients aren't optional choices for people, so we try to find creative ways to do that. We work over time to increase the energy and nutrient density of food selections and educating the individual on that. I talk very directly about this outcome research. The science is telling us that the more variety and the more you can do to incorporate these denser foods, the better you're going to do. And that seems to be very effective in helping people to at least begin the process. And then therapeutic meals with the dietitian, certainly, and with family-based therapy folks, working with their families on how to desensitize and do exposure work to lessen anxiety with some of these foods that are fear-based, or portions of foods that are fear-based, or nutrient-dense foods, or helping people to achieve enough variety to optimize their nutritional status so that they can better make use of therapy as they're moving along. We also want to integrate work with the therapist. I love how Dr. Moseman talks about how we're all working together here, because I need help. We all need help from those folks to use those cognitive, all types of techniques for anxiety management tools at the table. And then last on this list, but certainly not least, to have a collaboration with family and support networks to teach people how to be helpful in recovery and how to express concern and to support the new eating habits. Because since we know those are hard to maintain, we want to be sure we're supporting those and that the sufferer has those really good bolsters in place to help prevent backsliding, basically. Bulimia is a little bit different in that, as Dr. Moseman pointed out, there's more of a dysregulation or a chaotic nutrient presentation. So I think of that as the eating patterns don't present that stability that our human body likes. We like things to be steady eddy. The scientific term for that is homeostasis, but we like steady eddy. And bulimia is anything but steady eddy. And this unstable energy balance due to the behaviors and the impulsivity involved temperamentally really creates some conundrums. So you've got this, I'm trying to feel better yesterday, or I'm trying to feel better right now, engaging this dopamine system, and you've got a really chaotic food presentation. These folks have a hard time perceiving their need for fuel and when to stop, and difficulty discriminating need for fuel from other needs, and may get altered reward from eating and eating disorder behavior that really isn't about the biology of needing fuel. There's no scientific consensus on metabolic adaptation to bulimia. What that means is we don't really know if there are differences in energy needs. My experience would tell me not so much, that there's not the excessive metabolism that I've been seeing in the anorexia nervosa population. And this population has a real difficult time with energy balance and stability throughout the day. So there may be a period of time where there's complete food avoidance, and then there may be chaos with binging and undoing, and that creates a very highly variable energy availability for the brain to be able to function, make decisions, and do anything with their day, especially with regard to food decisions. Possibly there may also be an alteration in reward from food as well, and so again we're getting into these brain loops that are possibly altered in these populations that under the best of circumstances would require a steady, consistent nutrient load in order to cope with them. And here we have behaviors that have created the exact opposite of that. You have to consider temperament, that interest in novelty, that interested in a more outgoing presentation to the plate. These plates look chaotic. When I do meal work with folks, the plate does look chaotic. I have to consider the potential to use behaviors for other types of coping. Chaotic eating and difficulty establishing routines is very common, but the body likes that routine. So that's the challenge with this group, is the temperament and the brain loops are saying chaotic things, but we need the routine. There's a difficulty sometimes in tolerating normal-sized meals or in tolerating enough food to really do the job, in keeping, not undoing it. Not necessarily getting down, but not undoing it. We have to establish meal planning. We want to establish a pattern of eating that can work for someone's lifestyle and start to establish that consistency and stability so that that brain gets the nutrients consistently so that the therapy can possibly work. And I think it's really important to include periods of time where there isn't oral activity, because as Dr. Moseman said, there is some research suggesting that there is some tickling of areas of the brain that are similar to addiction, and I think it's nice to have times when you're not doing something with your mouth that stimulates orally that area. things like eating, drinking, smoking, gum chewing, breath mints, chewing your straw, putting your fingers in your mouth, trying to have times of the day where we're not doing those things to see if we can start to develop some distance from the chaos. From a meal planning perspective, we have to balance those energy nutrients, protein, carbohydrate, and fat to allow a more sustained energy curve. So we're trying to do a mixture here so that there aren't extremes in energy availability to the person or extremes in their hunger, which may trigger binge eating more often. And we want to plan a strategy to start to include things once that stability has been established that have been problematic, to tease out what are things that can be included in my life and how do I manage being in the environment with them or having them eat in my eating plan. The dietitian with this population is going to be working also on portioning reasonably and pace of eating, taking enough time with the food so that there is the ability to perceive some satisfaction from eating or learning how to pause and be able to think before making choices. Planning the therapeutic exposure and exposure response prevention activities, and again, family and supporter education on how to help this sufferer develop this steady, eddy, more consistent pattern of eating. Super important there to have that support system, because left to our own devices, the intuition of the folks is going to be that chaotic presentation until a new pattern is firmly learned and established. With binge eating disorder, there are some overlaps, I think, with bulimia. I have never worked with an individual with binge eating disorder that did not have a dieting history, so they too have this unstable energy balance due to chaos with eating. It's a different type of chaos. There's not the purging or the undoing, but there are frequent attempts to not eat, avoid certain foods, feel like I don't have permission to have this, that, or the other, that build in some of that instability. There's also a displacement of essential nutrients from binge eating, and this occurs in bulimia as well, in that when you're filling up on one thing, you may be missing out on another thing, and so I call it displacement. This dieting history is vast in many of our women and men with eating disorders, and that can create a deprivation experience that's pretty deeply rooted and pretty difficult to get through. And again, in this population, that alteration in reward where food may take on a bigger meaning than it would for the general population. And a challenge in discriminating between I need fuel and I have some other needs. So the need for fuel may get confused, and the need for socialization or time alone or other things maybe get confused. Energy needs in our binge eating population are highly individualized, but there is no scientific agreement again. So we have to, as nutrition professionals in the group and those that are out there, and we have to do a good job individually working on what people need. We have to do the same thing with the energy balance and stability. A brain that doesn't have the energy that it needs is not going to serve us well in terms of impulse control and decision making. So without that stability throughout the day, we're going to have a really hard time. We're going to be working on that. Again, that altered reward is a consideration and definitely has been demonstrated. We want to have the potential to use other things for emotional coping rather than eating. And the dieting paradigm that's prevalent in our culture really makes it hard, I think, for us to work with any of the eating disorders and to help them with changing their eating patterns when that's not as so culturally supported. In terms of meal planning, I'm a big fan of the non-dieting paradigm where all foods fit to lessen deprivation, that there are not complete no-nos. As I often say, no single food has the power to make or break your health in a reasonable serving. I like to establish a consistent pattern of meals and snacks that supports lifestyle and activity and balance energy nutrients, again, with those two extremes in mind. So there is a constant fuel source coming across that brain throughout the day so that folks are at their prime and best to manage impulsivity. Again, including those discrete times where there is an oral activity to not engage that piece of brain activity in beginning a binge process, and looking to the dietitian, nutrition professional to help with pacing and portioning and exposure work, and then families and supporters to help with maintaining those new habits as people enter into the world. It creates an interesting dilemma for people in my profession, because most of the training that we've received is on weight management from a traditional dieting perspective. And this traditional dieting paradigm considers a model of overstimulation and overreward for everyone, and doesn't really tailor to each individual person. And as you've learned from Dr. Moseman and myself today, there's a lot of individualization with these brain patterns for folks. And so to assume that one size fits all, I think is really inappropriate. There's emerging research that indicates that the differences in these neurological pathways in eating disorders sufferers affect their food consumption and their experience of eating. So for example, in the case of someone with anorexia, you have the simplify, simplify, simplify goal, whereas there's more of a chaos with bulimia and an eat, 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 soothe, soothe, soothe with our binge eating population. So the dieting paradigm, when you think about it, may actually potentiate these eating disorder behaviors by creating that malnourished state described earlier, and actually creating a brain that's less equipped to manage things. The paradigm for treating eating disorders is that non-dieting approach, and considering that all foods can fit and that there are no bad foods. But I caution that that has to be individualized, so that you have to meet the individual where they are and help them to work toward this. This isn't something you can just get to overnight. That it has to be, the paradigm needs to be focused on flexibility and inclusion rather than categorization and exclusion of certain unhealthy or avoidable foods. And that the paradigm needs to be focused on the long-term goal of a better connection with biological cues for eating, realizing that for some eating disorder sufferers, their brain circuitry may not allow this to be an option. I see some of these individuals in my practice that just need a simpler, more compacted, smaller approach. They need structure in their eating for a longer period of time or even a lifetime. But if that supports higher functioning, then that is possibly, given our knowledge and ability today, as good as we can get. I do believe, though, for most individuals, once they've developed the new habits and supported their body and brain chemistry and circuitry better for a significant period of time, which I usually measure in at least a year, that this beginning work of starting to connect better and do what I like to call connected eating, where we use our cognitive abilities and our biological cues to make reasonable choices, becomes a real option for folks. So to kind of wrap us up and give us about 10 minutes or so for additional questions, emergent science is clarifying our understanding of the neurological mechanisms involved in feeding behavior. It's also clarifying the role of these neurological mechanisms in eating disorders and how within that population of individuals eating behavior and feeding behaviors are altered. And we need to use these insights in informing our clinical care. So we'd love to entertain more questions whenever you're ready.
Thank you so much, Leah, and thank you, Dr. Moseman. And before we get into the questions, and I'd like to invite everyone to ask their questions now or type in their questions, I just want to go over some of our resources that you may find helpful. I want to remind everyone that this week is actually 2014 NEAT Awareness Week, and you can still get involved. Visit our website, neatawareness.org, and you can find there so much information on how to get involved, ideas and planning guides, articles, and just resources on eating disorders in general. Also, I'd like to invite everyone to take a look at our Parent, Family, and Friends publication, Making Connections, which you can find on the NEDA site under the Media Center tab. And we have all of our current and archived issues on there, including an article on the language of the brain, as well our PFN webinar series, which you can find under the Media Center tab on the NEDA site, including a webinar on binge eating disorder, and there's also a webinar on DSM-5, which you may find helpful. And we have our annual NEDA conference coming up, October 16th through the 18th. This year's conference, Thinking Big, Uniting Families and Professionals in the Fight Against Eating Disorders, and it will be in San Antonio, Texas. And there will be scholarships available, so please check on our website for more information on that. And Gerza Books is a great resource at www.bulimia.com for publications and books about eating disorders. And as always, NEDA's information and referral helpline is available. We also have the click-to-chat option, and please you can call 1-800-931-2227 or use the click-to-chat option. And we have trained helpline volunteers who can help you with referrals and information that you're looking for. We also have our NEDA Navigators program, and these are volunteers who have personal experience with an eating disorder, either themselves or in support of a loved one. And if you would like to be connected with the NEDA Navigator, please email pffnetwork@myneda.org. And we also have our NEDA toolkits, including the Parent Toolkit, Educator Toolkit, Coach and Athletic Toolkit, and all of these contain information about eating disorders, treatment options, how to support your child, insurance issues, and so much more. So I'd like to get into some of the questions that we have coming in now. Let's see here. We have one question coming in. Is there any research illustrating that a change in eating practices for those with BED actually changes the dopamine cycle that Dr. Moseman mentioned?
No, no, there's not that research right now. I mean, some of the problems, I think, with binge eating research in general is just the fact that it not being its own separate diagnosis just doesn't allow for, I think, people to write the grants and do things. So one can infer from studies that look at the dopamine cycle that certainly this, in binge eating disorder, in certain forms of obesity as well, that there is this sort of dopamine, especially dopamine 2 receptor risk-reward thing that that motivates them to eat, and they get some benefit from that. It also is shown that over time that you sort of do get some accommodation, so that the reward you get from food initially doesn't reward you as much and takes more dopamine to get that. How that is specifically subscribed out to binge eating disorder, I also have some interest in the fact of, between binge eating disorder and bulimia, we know what makes it similar. Well, what makes it different? What are those neural systems which have people stop at the binge and just do that versus, attempting to undoing, and how does that work, and how does that occur differently? But as there is with most eating disorder questions, for anybody interested in doing research, there's a lot of low-hanging fruit. There's a lot of good questions, and more good questions than there are good researchers.
Great. Thank you so much, Dr. Moseman. And we have another question here. Does it matter how long the patient has the eating disorder, this question specifically anorexia, when determining their energy requirements, or is it just a trial and error when observing weight trends and calorie counts?
That's a good question. So we actually can determine energy requirements using indirect calorimetry. There is technology that can be utilized to do that. That said, it poses some challenges for its use in especially clinical settings and outpatient settings in homes for families. So what I do is make adaptations in response to vital signs, laboratory data, and I include weight as a vital sign as well. in order to routinely increase until we're starting to support at a level where someone is starting to improve their health status pretty routinely. That can be really difficult, I think, for families out there trying to do family-based treatment, and it would certainly be all right to get some support from professionals for the parents providing the treatment to their child in order to just feel more confident with that.
Great. And then this question, with an eating disorder, how do you work with them to change the extreme portion of food?
To change the extreme portions in food?
That's the question. I'm assuming extreme in either way.
Extreme in either way. Okay. I'm a big fan of using some structure early in the game. So early in the game, I'm utilizing some recommended serving sizes for that moment in time for foods, and we actually practice portioning visually, which is really unusual because I know we feel like there's a lot of distortion, but I think folks have to learn what their portion distortion is. So I provide a visual portion that has actually been measured, not in front of the individual, and then they actually portion their plate to match, and we work then with, do they really match, and if they don't, what they need to put to make it match, and then them to see what the differences are visually. So we actually visually work on that. It's really kind of interesting.
Excellent. And I know we just have a little bit of time here, but I wanted to squeeze in these last questions. Can you talk on any differences that exist for those with anorexia who also binge?
That's a really good question. So in research sort of circles, when people are like trying to look at neurobiology and trying to follow that, even like we have a current study with NARCEP, they always talk about, you see in research circles, they talk about ANRs, or anorexia nervosa restricting, because I think there are thought to be some things neurobiologically differently from those, again, temperamentally and otherwise, that are more constantly restricting. They tend to be, again, more passive, more introverted, more anxious, more of that sort of turtle temperament. I think people that have anorexia nervosa that are binging or binging and purging, I think the literature would say that they're more commonly going to have a higher proportion of them are going to possibly switch diagnosis at some point and become bulimic, that there's probably something different neurobiologically that's happening, to allow them sort of to have the binge eating or to follow through with that, where a lot of pure restricting anorexics that will never transition anytime in their life, that just, it doesn't sort of neurologically do anything for them. So the question would be, as far as their impulsivity circuits, as far as what the binge does for them, and despite the fact that they're still obviously malnourished and low weight. So again, this is where the simplification of grouping diagnosis don't make as much sense. So the question would be, well, they're still maintaining low weight and they have all those state-dependent things from malnourishment, and yet they still have these impulsivity circuits. So you start to look at circuits in terms of what creates the binging or impulsivity, how does that coexist with the other circuits, what does that mean as they both develop and go throughout the life cycle as well.
Excellent. And I know we're out of time, and I just want to ask this last question. What is the definition of weight restored?
Oh, that is a magic question, isn't it? This is how I look at it. This is just my take. It is the weight at which an individual's biological natural body processes function optimally, not minimally, but optimally, while their neurological brain abilities and ability to use therapy is optimized as well. And it's highly individualized and very genetically mediated. We tend to have a body habitus or a body style similar to our ancestors, our parents, our grandparents. And so it may be that we can't just categorize folks into the minimal category. There are going to be some folks that are a little stronger or differently shaped than others whose health is optimized at higher weight, and some folks whose health is optimized at a little lower weight. There's going to be that diversity in the population. So it is a difficult question to answer. Clinically, I can say when you're there, you know it. It's guessing that sometimes is the more challenging, not identifying when it's been achieved. It is easy to identify when it's been achieved. I don't know if that makes any sense at all, but because it's a very complicated question that I don't think as treaters we have great answers to other than we clinically know it when we see it.
Great. Thank you so much. And I know we're out of time, so I just want to briefly thank Dr. Scott Moseman and Leah Graves for joining us today and sharing their expertise and knowledge on this subject of neurobiology and disordered eating, and for this very informative webinar. And I want to thank all of you out there for joining us today. And you will receive a short questionnaire by email about this webinar. And we really appreciate you just taking a minute of your time to offer your feedback. We do welcome your feedback and listen to what you have to say. And if you have ideas for future webinars, please email me. You can email me directly, ellen@edomingos@nationaleatingdisorders.org. So thank you all very much for joining us today, and enjoy NEAT Awareness Week, and thank you, Dr. Moseman and Leah.
Great,
You're welcome. Thank you.
Okay.